첫 번째 이미지.
Dr.
첫
Sungwan
번째 이미지. Yeah.
will you introduce your team and your case?
Yeah. This case is maybe presented by another Dr. Lee, Dr. Park, Veterans Hospital, and Ulsan University Hospital. Dr. Park, Dr. Lee. So I wanted to introduce our case.
Yeah. Let me introduce my case. This patient is 76-year-old female admitted for intermittent chest pain during hemodialysis. She had a previous history of PCI with DES at proximal to distal LCX and distal RCA to PDA 5 years ago. And she underwent PCI with DES for mid-LAD 2 months ago. Her conventional coronary risk factors were diabetes, hypertension, and dyslipidemia. And her past medical history were previous PCI on ESRD and hemodialysis. And also she had a history of ventricular fibrillation arrested due to hypokalemia, and she also had a PAOD at right common femoral artery. He had also percutaneous transfemoral angioplasty at right common femoral artery. Next. And next. Her echocardiography shown a carnage of basal inferior wall with near normal average systolic function and moderate to severe functional MR. And her thallium SPECT was shown reversible large size moderate decreased perfusion in basal imperoseptal and mid basal inferior wall. This thallium SPECT was matched with echocardiography. Her syntax score is 16 and CTO score is 2. Yeah. The target lesion was the mid RCA CTO.
So we now check our baseline angiography. As you can see, LAD stent looks patent and good collateral connection to distal RCA portion. So this patient already have some previous PCI history, so we can get the previous angiography. Could you next? This patient RCA is totally occluded. Yeah, looks easy.
Looks short, not
yeah,
easy.
Looks short. Yeah, I know. So this patient, we can review the previous patent RCA. So could you show?
previous
이전 RCA.
이전 거.
텍스 RCA 보여주세요. 노멀. 그거요.
Yeah, this is the previous stenting time. We can check the previous angiography. So maybe previous angio is very valuable information because of we can assume the track course. However, relatively short, so maybe straightforward. There is a little bending. You can see in CTO segment have some bending.
So that's the 5 years ago NGO.
Yeah.
But it's surprising for a hemodialysis patient, not so much calcium.
Yeah. Depend on the patient risk factor and his weight. As you can see, the RV branching in the proximal segment, at that point you can see a little bit stump. You can see?
Yeah, there's a small notch.
Yeah. So that is our target to puncture in proximal portion. However, if there is no stump, maybe IBUS guidance is very maybe give us some information. However, this patient, as you can see, the previous angiography gives some good information, proximal cap portion.
Okay.
So is there any comment?
Any comment from the panels? So you're gonna do the integrated approach first, or?
Yeah. If the lesion is longer length, maybe I try to the lateral approach. However, this patient is very short, and we know the proximal stump like the not. So I can try to first and soft wire. How about?
How do you think, Dr. Shite?
Yes. I think that the entry point we can see a little bit with the stump. Maybe I would like to try the first is a soft wire, and if not, I would like to use Gaia first and make sure by IVUS for entry point. But I think the important part is the CTO, the entry side is an angulated lesion. Maybe once penetrated, I will de-escalate like a soft wire change.
Yeah, fully agree. Is there another opinion? Please give me so many opinions.
How about using the IVUS at the entry point for finding?
Yeah, give us some good information for entry point to the composition. Which wire is the best for the puncture? Maybe IVUS is make the good information.
I think also you need IVUS anyway, because this is a
Yeah.
diffuse disease, and probably you'll have to decide, because last time at 5 years there was a nice treatment distal, but the artery disease progressed, and probably you need to stent the whole artery today.
Yeah, that's right. I like IVUS always. However, today, during the stenting procedure, I enjoy the IVUS guidance. However, there is some stump who is needing puncture without the IVUS. I want to show. Next. So we prepare the cochlear, and the tip angiography also make the image clear. You can see. So I choose the soft wire. I like always choose the initially soft wire. Field XTA, field XT is my favorite first wire. Any situation. So depend on the proximal cam morphology, we can choose initially the intermediate to the high penetration pulse wire. However, I think this portion is maybe soft wire can work because of the calcification is not so much, and in CTO segment some angulation. So hard wire make some difficulty to negotiate that kind of the angulation. So I wanted to use the soft wire initially, not Gaia one. I wanted to choose the field XT. How about?
Yes, I think that's a reasonable choice, especially as you see on your reference image that there is immediately an angle.
Yeah. So next, I tried the XT wire. I like XT compared to XTA. You can see maybe proximal cap is engaged easily. However, there is some bending portion, so maybe we need the advance of the cochlear because of the need the backup support strong. Next. So I think the maybe wire is going to the lumen. However, wire movement is very nice. I like this kind of movement. However, next. 안지오그래피 없나? 안지 안 찍었나? This wire is going to the next. Previous one. Okay, next. So there is some wire is slipping to the side branch in the angulation portion. So I wanted to make the wire shaping is more acute. At that time, we tried to next. Wire is going to distal lumen easily. Next. So wire is going to the easily. The time is just 5 minutes. So I'm so sorry. So at this point, I think I wanted to say the previous angiography is very important. And CT angiography is maybe replace this kind of the previous angiography. So CT angiography is also important to have some good information, CTO segment.
So that wire was XTR or
XT.
XT?
I like XT.
XT.
Yes, I agree. Also, the XT is more passive. The XTA is more aggressive. Yeah.
So Corsair is advanced easily, and then wire changed in Seoul, and the balloon dilated. So I'm so sorry.
So it's time to move.
Yeah, angiography. This is post-balloon angiography.
No, but I don't think it's a trivial decision now. It's not trivial how to treat this patient because it's diffuse disease from top to bottom.
Yeah. So from now on, we check the IBUS, and then we decided our stenting plan. Because of the, as Dr. Warner commented, maybe full segment, full lesion recovery is required.
So any comment for this case, please?
Yeah.
Thank you for a nice procedure. It's okay.
You can go.
Okay. So thank you for a nice procedure. So it's good point is a Corsair position. First, you put your Corsair position is far away from the entry point of CTO.
Yeah.
But its point is entry point of this is a bent curve. But nextly, you point the Corsair stays entry point of CTO to straight the vessel. So easy by the wire control. If Corsair positions are far away from an entry point, this is a bent curve. Guide wire control is a very difficult situation. So finally, you push a Corsair to enter point of CTO, so the easy guide wire crossing. Maybe I might comment.
Thank you for invaluable comment. I always try to advance wire and microcatheter simultaneously because of the strong backup support always important. And then after wire change also, we need some torque control. At that time, is the microcatheter is maybe good supporter to make the good control of the wire.
There are bent curves before the entry point of CTO. So it's the one point. So maybe I'm an operator. I use a double lumen catheter, more supportive, and to stretch the best of the proximal side.
Yeah. However, I don't like the double lumen catheter because of the distal port is usually directed to my intention. So there is some struggle to make the entry puncture from the distal port of the entry. So I always use the microcatheter at first. If there's some situation, in special situation, I wanted to use the double lumen catheter.
Yes, and I also agree with your opinion. In this situation, the Corsair has enough backup force. In terms of the direction of the angiography, I think around the CD or around there is sometimes RAO or RAO corridor view is very important because this landing zone is angulated as already Dr. Shita said. So how about the projection of the angiogram?
Yeah, also very important point during the RCA intervention. Even the LAD circum intervention, I think is another projection comparison is very important to confirm the location of wire. Always.
Yes.
Is right?
Very good. And so it's time to move to another classroom?
Yeah. Sorry.
Doctor. No, you did a very good job. Thank you for your dedication.
Yeah.
Let's move to the case 4.
Case 4, yeah.
Dr.
Case 4.
Toshiya Muramatsu Sensei. Not ready yet. Okay. Dr. Muramatsu Sensei,
Yes.
now you are on the screen.
Okay. I will case presentation, please.
Let me
Please introduce yourself.
Yeah. I'm Dr. Go from Seoul St. Mary's Hospital. Let me introduce our team.
As you know, the Dr. Brahmaji is a very famous CTO person, and my right side is Dr. Gyusam Lee. Yeah, let me introduce our case. Our patient is 62-year-old male. He was admitted for effort chest pain. His coronary risk factor was only hyperlipidemia. His initial angiogram showed cerebral vessel disease with the left main bifurcation disease and chronic total occlusion of RCA. Next. And his clinical manifestation is stable angina. Next. And silent spec showed the reversible large-sized mild decreased perfusion in mid-basal inferior and basal inferior septal wall, RCA territory. Yeah, next. Next. And CT angiogram, next. The length of CTO lesion is more than 20 millimeters, very long CTO lesion. Next. And the angiography, would you explain the angiography?
Okay, I will show you today's angiogram. System is a bilateral 7 French, AL1, EVU 7.5. And this is a bilateral injection. Right coronary proximal CTO after the branch of the conus branch. Next, LO view. And I will check the collateral angiography next. Already stent was in place of the left main to LAD and atrial channel, two atrial channel. And the septal channel is diminished compared to the diagnostic angiography. I'm not sure the reason. And distal LAD has some epicardial channel to connect it to the PD branch, but the problem is PD branch is another CTO just after the bifurcation, as you can see that. So
Yes.
this case is a two CTO, proximal right coronary and PD branch CTO. So this is in my situation. So I will show you the IBUS. I will check IBUS from the conus branch to the RCA. Do you see? You can see the IBUS?
Not yet.
IBUS.
Okay, now we can see the IBUS.
conus branch가 제일 I think. conus branch 제일.
아트로핀.
So you have we lose the IBUS image.
환자부터 깨워야
Okay.
될 것 같은데. 환자.
Oh, okay. Real
네,
life.
하세요.
The bradycardia?
Yes, bradycardia.
Okay.
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 I pull out the whole system.
Okay.
So there are much aortic valve AR here from CAG angiography. AR is affect for the blood pressure or bradycardia? No?
Blood pressure is okay. Just the bradycardia,
I think that conus.
maybe conus.
If the patient is okay, can we
Yes.
see the IBUS?
Yeah.
Is there IBUS commentator over there, or who are you gonna talk?
We do the IBUS ourselves, huh?
So I was pulled back to the branch,
Okay.
And this is the entry point of the right coronary CTO.
So no calcium.
Calcium. A little bit, tiny calcium. So.
Let's see the takeoff point. Let's pull back slowly. Okay, over here. Okay.
So on the angio, the occlusion looks shorter than on the MSCT. Is that correct?
Yes.
Yes.
True CTO
Yes.
segment is something like 1 centimeter or less than 20.
So please discuss. I'd like exchange the guiding catheter small size.
Okay.
Yeah.
And do they do the kissing balloon at the left main to circumflex in the previous stenting?
Previous.
I'm curious about LMT is T-stenting or curot? LMT?
At the time,
At the
the
time.
previous PCI. Anybody know?
With the side hole. Do you have a rancher?
The
7 French?
is a large diameter difference. I don't think it was culotte. It must have been rather T.
Yeah, maybe T-stenting or top.
And the side hole.
Yeah. T-stenting with a kissing balloon, I think. Any comment for this case? It's relatively short segment, but and less calcium in IVUS. It looks possible to IVUS-guided penetration of the proximal cap. And collateral channel comes from circumflex and diagonal and distal LAD as well. Septal channel is there any good interventional septal channel?
No, there was no septal channel,
No
but
septal
anyway, it doesn't help to get into the PDA first.
Yes,
I think
yes.
you need to treat the proximal CTO first, and then see whether you get a small, short PDA. So any suggestions from our panelists?
Please. Many suggestions, please.
What is the first wire choice?
Yes, maybe that we can select the integrated approach with IBAS guidance. So maybe we can puncture the from integrate. And if integrate has been failed, of course, we can see that so many collateral channel. So, but the PD branch is occluded or the subtotal region is there. So usually the connection is from circumflex is very nice. So we can use the circumflex epicardial channel for the retrograde approach.
For the retrograde.
So operator change guide catheter. If change guide catheter, after change guide catheter, hemodynamic station is not stable, I don't touch first electrode approach, only an electrode approach. But if vital levels or blood pressure and heart rate is stable, I consider the electrode approach.
Good.
So then,
Matsubara sensei is here?
yes.
Any comments?
Yeah,
No comment.
No comment.
So the whole live session is only for you, Dr. Matsubara.
No, well, probably we should have a look on the IBAS finding in Dr. Lee's case also later.
Okay.
So you changed from a regular AL1 to a AL075?
Short tip.
Short tip, okay.
Yeah, tested. And I think it is necessary to put the stent for the ostium of the right coronary at first, maybe. Tested. Tested.
Another case of this, another concern of this case is whether we have to treat open the PDA CTO at the same time. Because if we don't open it, then the distal territory, perfusion territory could be small. Then the reocclusion or risk of the stent could be increased.
So what do you do, the treat or not for the PD branch CTO? Would you like to discuss?
Well, first you have to come through the proximal, I think. And then the PD will be the smaller problem.
Yeah.
Okay, let's move to the Dr. Seungwan's room. Let's see the final imaging of Dr. Seungwan. Can you move to the another cath lab?
Yeah.
In a moment.
Yes.
Dr. Seungwan,
Yeah.
will you explain the current situation? I heard that you almost finished.
No.
Not yet?
미안해요. We put the stent in from the distal stent 3.0, 38, 3.5, 38. Two stent is implanted. And distal RCA, ISR lesion, focal ISR lesion, I wanted to check again. And then we maybe have a plan to DCB. Yeah, this DSRH now still untreated, so I wanted to use the DCB. balloon first. Previous stent size 2.75. So I want to inflate the 2.5 balloon, and then I want to use the DCB because of the I was finding showed the focal instant restenosis.
How about the ostium of RCA? Is okay?
It's okay.
So what was the vessel diameter in the IVUS finding?
In mid portion is 3.0 and proximal portion is 3.5. So I put the same size of the stent. This is 2.5 balloon. Please test. Okay, 가자. Okay.
8,
10.
10,
Maybe waist, air,
no, air.
dimple, maybe air. Okay, one more time. Go.
8,
10.
10,
Okay. Could you give me 12?
12,
Deplete.
different.
So, could you give me IVUS? So I want to check the IVUS finding in focal ISR lesion, and then I wanted to use DCB.
2.5짜리가 있을 건데 2.5 포칼로.
But if there remains some significant edge dissection, I don't think DCB would be the option.
Yeah.
Rather, 8 millimeter extension of the stent
Yeah.
doesn't make too much difference whether you have 100 or 108 millimeters.
Yeah. So I want to check. Let's go. Distal vessel size around 2.75 or around 70. Looks good.
Quite good.
Still, edgy.
Maybe just 8 millimeters of stent, and then it's perfect.
짧은 거 하나 줄래?
아니.
스텐 제일 짧은 거.
We do a lot of distal DCB, but in diffuse situations, not when there is a focal problem.
2.75.
How is it in Japan?
2.75죠.
Kenya? Or
DCB indication is limited to small vessel and in-stent restenosis only. But the result is quite well for in-stent restenosis. But still we are waiting for the result of diffuse small vessel.
So I want to put the stent 2.75, 12.
Okay.
Because the remaining vessel segment is not so long, so I wanted to save the distal part of a normal segment. Just a moment. Okay, test please. 이 정도? 가자.
In Korea, no limitation for stent use.
Yeah. Very country.
The number of stent.
Now it's getting more flexible.
Oh, really? In Japan, it's 2 or 3. The
only?
maximum.
One more time.
procedure.
One procedure.
Yeah.
Oh,
10,
That is the
12,
main problem for us.
14, people.
so more strict than Korea. Huh?
14, 16. Okay, 16.
16.
Okay, people.
He's doing procedure.
So I want to check IBUS. In the middle segment looks good.
Yeah, looks like an optimal expanded stent.
Yeah.
French.
French. Oh. Yeah.
Oh, good.
Stent is 2.75.
Very good. Okay, Dr. Sungwani,
Yeah.
thank you for your nice case. I think
Sorry.
that's too easy for you. So we're gonna move to the Dr. Asakura's case. Counselor.
Yeah. Thank you.
Thank you very much. Dr. Asakura Sensei,
Yes.
you
I
are
have
now
to
on the
talk
screen.
long story.
Okay. I think around
I will
this,
show you
yes,
around this part.
reverse card.
Yes, after ballooning with 2.5, little bit wire went into the true lumen, but it doesn't go into the guide catheter. So I used guideline, GuideZilla.
GuideZilla. Okay.
Okay. And I did externalization with RG3 and balloon dilatation. But I couldn't get a PL branch. So I introduced Crusade catheter retrogradely. And this is Sion wire from PED to PL branch.
Oh, you put Crusade catheter
Yes,
retrogradely
yes.
without dilation.
Yeah, with a dilation. And this is 2O balloon. I dilated around here in order to do a reverse wire technique. As you can see, angle is very acute.
Yes.
I put 2 stent. After that, I did reverse wire technique. But this wire is Sion black.
So now you have 2 Crusade, one in retrograde and one in antegrade?
One.
One in antegrade.
Yes.
What is the microcatheter in retrograde?
This is balloon catheter.
Balloon catheter, okay.
Yes. I have to create enough space to do the reverse wire technique.
I see. But angle looks very, very acute, huh?
Yes. Okay, 2.5 balloon.
2.5.
So you're, for the reverse wire technique, you are using the Seoul black?
Seoul black, yes.
Seoul black. And that reverse, the area of that reverse angle is about 5 cm from the distal. Is that right? 5 centimeter from the wire tip.
Yes.
Looks like.
I think that the PL branch, there's two guide wire now. So
Yes.
there's an option like retrogradely put the balloon to the PL and trap the antigrade wire at the PL. It's
that's
easy
good.
to go.
Yes.
Very good.
Thank you so much.
Very good recommendation.
Yes. Okay, 4 is here.
That's very safer. I think.
Safe and
Thank
easy
you.
to introduce the balloon. Huh? Okay, that's very good. Huh?
ワイヤーみたい。UB3?
UV3.
So to use the double loom wire, double loom catheter through the collaterals usually is possible after you've passed with the Corsair without
Yes, that's right.
dilatation.
Yes.
And
Most of the time.
even with the Crusade, even though
Yes.
the Crusade is a little bit more bulky than the Sasuke.
But we have a new Crusade. Tip side is smaller than Sasuke.
Okay.
And most of the time, after the crossing of Corsair, Crusade also can pass through the septal channel.
Oh, really?
I mean, this is a very frequent situation in RCA CTOs that we have to fight for the crux, because without the crux restored, it's only half the vessel.
Okay. Okay, Dr. Can we move to the Dr. Muramat's class lab?
Yes.
Okay. Muramat Sensei.
Okay,
Now we are
just
on
a
the
moment,
screen.
just a moment. Wait a moment. Replay. Okay, so I did change the guiding catheter back. Back. Back before stenting. Back.
Stenting.
Yes, I will show you the back. No, back.あれ? I will show you the anatomy of the right coronary. So, first of all, the patient has a bradycardia during the procedure. The reason why, I think one of the reasons is you should notice of the tip of the guiding catheter. It's like a fish mouth. The pressure is maintained, however, the proximal right coronary has a tight stenosis. So I'd like better to put the stent at first at this position. And I changed to the small size balloon, 1.02 short amplatz, and put the stent for the ostium of the right coronary, 3.015, and post dilate 3.5 balloon here. Next. Next. So after the stenting, pressure is much better than before. So that I'd like to try crusade, introduce the cons branch and trying to negotiate Gaia second, and a bilateral check.
Did you put an extra bend on the Gaia, or was it straight out of the box?
A little bit extra bend.
Okay.
So in this time, it is a very important issue. So as you can see, it is in the Crusade catheter is already wedged in the CTO entry point. So in this picture, bilateral angiogram, but just only see the collateral flow. So I draw back the Crusade catheter a little bit back to the ostium, so more easier to see the antegrade and retrograde flow. Already done. これか。So now in the successfully introduced the Gaia into the maybe in the true lumen. So this is in my situation now.
Okay. Very good.
I will
Any
show the
comments?
So now you're advanced pretty far. Is it already towards the PDA?
not yet, not yet. You say that first to put the stent for the proximal CTO.
Yeah.
I'd like to show you the picture, okay? Bilateral. Yes,
Okay.
this is in my situation now.
The true lumen in the PL almost.
Yeah. So after the dilate by balloon, and I will check eyeballs. Maybe you can see that this vessel is a very diffuse stenosis. Not only CTO side, but also distal side is very diffuse. I think it should be necessary to put the long stent from before bifurcation to the ostium.
Yes, looks like.
So after that, the second second discussion is how to treat a PD branch CTO or leave it. How do you think?
No, well, you should give it a try. I think, as we discussed, it's a long territory. It's a large territory. It's
maybe for discussing the PD CTO, we need angio after you put the stent, long stenting for the better image to see the.
As you can see, the PD is not small. As you can see,
yes,
this
yes,
is right.
Yes.
But very well collateral supply from the epicardial channel from the distal D. Well, anyhow, I will dilate the proximal. Okay. 2.5 balloon.
Okay, we're gonna come back. Let's move to the Dr. Yasakura's Castellab.
Okay.
Yasakura Sensei, now you are on the screen.
Yes. Okay. Now I will try to deliver the calibrated catheter.
To PL?
Yes.
So you did a dilatation there? Could you advance the balloon and pre-dilate?
No, not yet.
In case of reverse wire technique, I think the difficult part is that introduce the guide wire more deeply. Several times we're gonna meet that angle we made is prolapse to the main branch every time.
But this situation is he used the valve anchoring inside the PL. So the
prolapse. Yeah. So maybe putting a little bit guide wire
Okay, that's good.
and then going up.
I think without anchor balloon,
It's a very difficult situation.
almost impossible,
Yeah.
that angle.
So now we can change the guide wire. It's a more support wire, I think.
Sienna black, Sienna blue.
Very nice.
Is there any tips to introduce the microcatheter after the reverse wire? When the wire is going to the prolapse to the main? Not this case, I mean.
Yeah, it's very difficult if the lesion is angled. Like you mentioned, that Sion black or some, we usually use the reverse wire is a soft wire and no support force. So that is the most problem to go the bended lesion. Maybe the tip
One
is
tip is
should the
how
guy-
to create a second cup.
Yes.
yes.
Okay, please show.
And also go deeply possible.
Okay, now we can see.
Yeah, it's a Sion black.
Oh, so less than 5 centimeter you made, huh? It's like a 3 centimeter, looks like.
The important thing is to make
We cannot hear Dr. Yasukura Sensei's mic. Okay.
not single, multiple angle is very important.
You want? Do you want?
You want?
Yeah. Sean blue. Blue. Yeah.
According to that acute angle, I think the Sion blue may not have a sufficient wire for integrated ballooning.
I think
It's okay?
I think the angle will be stretched after
will
the
be
iris.
stretched. Okay,
I think
okay.
it's not so much calcium, it will be flexible. The question is how to approach now with stenting. Did you do IVUS already in this PDA? Do you know about the disease at the crux?
Can you show us? I was yeah. 아까 PDA.
I was from PD.
No,
Okay.
yeah.
I think at the proximal part of main vessel bifurcation, there is a plaque at the side of a side branch orifice. So if we implant the stent at this side, the possibility of plaque shift to the orifice of a PL. I'm not sure. But
It looks like a membrane or some subintimal crossing there.
yeah, this is a plaque in at 12 o'clock.
if you stent, you have to stent into the PL.
Would you please show me IVUS again to put him back?
IVUS again. May we see IVUS again? Okay. Pull back.
Yeah, pull back.
I have IVUS.
Maybe it
This
would
is
be good.
orifice of PL.
Yeah, it would be good to do a kissing ballooning before deciding. Maybe you can crack this membrane and then decide about stenting.
Okay. Now we check IVUS.
Okay. From PL?
Yes.
Yeah, yeah.
Okay.
Did you do a dilatation? No, not yet.
No, not yet.
Do you still have the balloon in the PL?
Now it's a PL.
Yes.
Yeah, there are too many artifacts.
Too
now.
high, yeah.
balloon 이러고 있다. 여기?
Retrograde.
아.
Yeah, I was not moving.
No, no. That's right.
Yeah.
Yeah, I see. I'm sorry.
Yeah, yeah. That's,
Okay, please record.
yeah.
It's 2.5. 2 or 2.5 around. It's 2.
Oh, looks open.
Looks open,
Yes, yes.
Probably you can get away with one stent towards the PL.
How should I do?
I think that the PL orifice is okay. The problem is proximal main vessel of PD site. Proximal main vessel of the bifurcation. There's a plaque, right? From the pullback from PD IVUS findings. So
You mean I should put PD branch, stent to PD branch?
I'm afraid that if we implant the stent crossover to the main vessel to the PD, there might be a plaque shift to the orifice of a PL site. Might happen because there is a plaque at the 12 o'clock at the proximal main vessel at the bifurcation.
Well, I think the amount of a plug is not dangerous.
I don't know. It's
I would put the stent towards the PL. If you're wrong, you still have the PD wire to recross and then...
yeah, it depends on the vessel size, but if both PL PD is the same size, maybe implant the stent to the PL side is a safer way because the plaque is PL side proximal main vessel.
Anyway, in
Is
the
a good
retrograde
idea.
situation, when you are retrograde through the PD is secured.
You know, how about do the angiogram in this situation? You already covered the stent in the proximal side, so you can do the angiogram in this situation. both vessels is small, right? Or if the angiogram show the good flow, not stent is also a possible option. I'm not sure, but distal part of the
Okay.
stent, still
Let's
there's
see.
a stenosis, distal
Let's see
edge of the
the-
stent.
Now the PD is coming.
Yes. So
Yes, there
this
is not
side
much
okay.
plaque. Maybe drug balloon down.
I think that narrowing is not due to a lot of plaque. It's a little bit of a plaque, maybe 20%.
Looks good.
Yes.
But the PD, the PL branch is really coming, so it's a huge territory.
Yeah, I think
Yeah,
just
I think
put
it's
the PL.
Okay, I will put stent to PL 2.5 2.5 短い。Yes, 15.
So in the angiogram, we can see some hematoma or something. Is it just a hematoma or some kind of extravasation? Because is in IBAS findings, this side of the RCA, we can see the very big hematoma in the IBAS findings. So in the angiogram is also, we can see some protrude, the contrast from the stent, the outside of the vessel.
The mid part of the stent, right?
Yes.
And the ostium doesn't look,
Looks good, huh?
needs some more treatment.
Yes.
There is some dissection there.
Okay. Okay, let's move to the Dr. Muramachi Sensei's class lab. Muramachi Sensei.
Yes. Now I put the stent with the proximal parts of the diffuse region, 12.
12.
Now. And the 30 stent over the next. This is a 40?
Yeah, 40.
Yeah. 23? 23? 330 stent.
3.0.
So I will show you the after ballooning picture. Let me see the last picture.
마지막 거죠. 마지막이죠.
Last one.
Back. So this is after 2.5 ballooning. And I will check IVUS. The plaque is very diffuse, and I decided to the long stent from the just before the bifurcation to the proximal. Okay. Okay. 30.
22.
So how many stents was allowed on procedure in Korea? 3, 4?
Per procedure, maybe about 5 stents.
5? Really? 아, ちょっと短いな、ほら。ごめんなさい、もう一個来るな。ああ。
A little bit
Okay,
short.
inflate.
Yeah.
Inflate. Yeah. 8,
12,
12,
14,
14.
down. Inflate.
After he heard that 5 stents are allowed, so he takes shorter ones to get to the number.
But it's depending on the situation. If you put a shorter stent without any reason, then they will not accept to use short stent. So how is the ostium of the PD? Is there no calcification?
Ostium of the PD has a calcification.
Calcification.
By IVUS. I will show you.
Okay.
IVUS. I will show you the IVUS.
Okay.
Product from the PL branch. So this is the product from the PL branch. This is a PD branch coming with the calcium, right? So what can I do? Any opinion?
Okay, so but entry point of a PD branch, there is a small lumen. So and around the small lumen there is a calcification. So maybe guide wire get close to entry point from IVUS view. My comments. Entry point is 3 o'clock from IVUS view.
Yeah, there's a little bit of room to go in. Any comment?
So I think this will be a very good case for IVUS guided puncture, simultaneous IVUS guided puncture.
This is a image of the distal CTO.
Well, here it looks the angle to puncture seems to be quite favorable.
Really?
Yeah. Yes.
I believe you.
But how about bringing a microcatheter into the distal LAD, maybe to avoid so much of contrast? Because now you only want to see the PD.
Yes. Okay, so now I will try open PD using by the microcatheter. Give me a crusade.
If we look at the angio right now, that we can see the severe aortic regurgitation now dramatically improved. Perhaps the sense brady at the beginning of the procedure comes from the iatrogenic severe AR. That was commented by my neighbor panelist.
Okay. So what kind of wire did you recommend?
Dr. Warner?
Maybe you have the Gaia 2 already. I think it should work like it worked in the proximal.
Gaia 2? Let me see the last picture. So to stop the roll map.
Okay.
Okay, I'll start with Gaia 2.
Is it the regular Gaia 2 or the Gaia 2 next?
Regular.
Regular, I think.
Regular.
Okay.
Give me a new crusade. Yeah. This crusade inner lumen was broken.
Maybe put a wire into the LED, huh?
Okay. Could you proceed?
Okay, in the meantime, we'll go to the Dr. Asakura's lab, and we'll come back soon.
Okay.
Dr. Asakura Sensei, we only have 4 minutes.
Okay.
So please explain your situation.
Okay, I put 2,550 millimeters. I put one stent crossover the PD branch. And after that, I lost the guide wire again.
You lost guide wire to
Yes.
PL?
So, both.
Both? Oh.
But you had done a pot. You had dilated proximal at the crux. We saw one balloon, one bigger one.
So you already put the PL stent?
Yes.
And you lost the 2 wire.
So now there's no wire at all? The RG3 is removed?
No, RG3 is still exists, but
So the RG3
this stent is behind the stent.
Yes, it's behind the stent. So that's a reminder we need to be careful with the RG3 behind the stent. How do you remove the RG3 when it's behind the stent?
But this time is the behind stent length is very short.
I know.
So that maybe the 7 or 6 millimeters. I think it is not issue.
Would you usually push the retrograde microcatheter back into the anterograde guide for removal despite this?
No, that you shouldn't do because then you go below. But
Exactly.
what my routine approach to remove RG3s is antegrade microcatheter.
Of course.
Yeah, on the RG3, advance the antegrade microcatheter.
So for RG3 under the stent strut, it's very important to remove carefully. And I agree with Gerald, you should put an antegrade microcatheter to the point and not push the retrograde microcatheter all the way across. Also, when you remove it, you should have a balloon inside the stent so that after you remove it, you re-balloon. That is the safest way to do it. So you shouldn't push the retrograde microcatheter back into the antegrade guide in this situation.
At least before post dilatation, he should remove to the RG3.
Yes.
Okay, what is your next plan to confirm the PD?
Yes, and I use drug delivery balloon if necessary.
DB to the PD.
Yes.
Okay. Thank you for your contribution. Thank you very much for your effort. Thank you. Let's move to the Dr. Muramat's lab.
Yes.
Yes.
I will try Gaia second with Crusade catheter.
Okay. Dr. Muramat Sensei, it was a very nice case for educational, and please keep do your effort for the PD. Now it's time to close this live session.
Okay.
Thank you very much for the moderators and panelists, and thank you very much.